We're going to start off by simply telling people or sharing the definition, meaning, and associations of recurrent urinary tract infections. There is going to be some overlap between my talk and some of the other talks, but I think this is an important message if it comes back again and again, because those are the crux that we need to know. So UTI has got different scenarios. You can have cystitis, pyelonephritis, recurrent UTI, catheter-associated UTI, UTI in men, and finally urosepsis. And you can have uncomplicated UTI on one side with low risk, with complicated UTI on the other side with high risk. If we cover some basics, what is a UTI? It's basically inflammatory response of urothelium to bacterial invasion, usually associated with bacteria and pyeluria. Talking about bacteriuria, it's a presence of bacteria in the urine, and yes, it can be symptomatic or asymptomatic. And pyeluria is presence of white blood cells in the urine, which is usually suggestive of infection or inflammatory response of the urothelium. Going forward, what is recurrent infection? It's one that occurs after a documented successful resolution of an antecedent infection. And prophylaxis usually is given for prevention of reinfection or through administration of usually antimicrobial drugs. And nosocomial or health-associated UTIs are in patients who are hospitalized. Again, going through some more definitions, what is cystitis? Generally regarded as clinical syndrome of dysuria, frequency, urgency, occasionally with suprapubic pain. Pyelonephritis similarly is clinical syndrome of chills, fever, and flank pain accompanied by bacteriuria and pyuria. And chronic pyelonephritis, usually it described as a shrunken, scarred kidney diagnosed by morphologic, radiologic, or functional evidence of renal disease that is usually associated with UTI. The bacterial count, it's always interesting to see how the bacterial count works. The definition of significant bacteriuria comes from almost now 80 years ago or 60 years ago through pyelonephritis in pregnancy. But the clinical relevant bacteriuria is 1,000 colony-forming units per mil in uncomplicated cystitis in females, 10,000 colony-forming units per mil in uncomplicated pyelonephritis in females, and 100,000 or 1 lakh colony-forming unit per mil in females, or 10,000 in males in complicated UTI. So it has to be kind of correlated with the clinical relevance, and it's not usually one figure. And then any bacterial count in suprapubic puncture specimen is considered as significant. What are the different types of UTI? You have an uncomplicated UTI where an infection in a healthy patient happens in a structural and functional normal urinary tract. And then you have a complicated UTI, which is associated with factors that increases the risk of acquiring bacteria and decreases the efficacy of therapy. And some broad examples would be structural or functional abnormality, host is compromised, or the bacterial virulence is quite high, or there is a high antimicrobial resistance. If we were to just go through briefly then, uncomplicated UTIs is limited to non-pregnant premenopausal women with no known anatomical or functional abnormalities. Complicated UTI, all men, pregnant women, and if they have anatomical or functional abnormalities, and other factors such as indwelling catheters, renal disease, immunocompromising diseases, etc. Recurrent UTIs, at least 3 UTIs in the last year, or 2 or more in the last 6 months. Then we call it as a recurrent UTI. And finally, catheter-associated UTI is a UTI in patients who have had a catheter placed within the past 48 hours. Just to recap about the magnitude, 30% of females will have a symptomatic UTI that require antimicrobial therapy by the age of 24. And nearly half of all women will have a UTI during their lifetime. Can you imagine the magnitude? It's massive. And this is the kind of prevalence. So generally, the prevalence of bacteria in females start with the onset of sexual intercourse, and then it steeply increases between the age of about 17 to 25, and then keeps on increasing in a more gradual manner. Symptoms, we probably all know, lower urinary tract symptoms are your frequency, nocturia, dysuria, secondary enuresis, suprapubic pain, and hesitancy. and upper urinary tract, it's a bit more general, such as fever, vomiting, generalized loin pain, upper or central abdominal pain. This is an important concept, again, asymptomatic bacteriuria, and generally there is no symptoms, and the bacterial growth is more than 100,000 colony-forming unit per mil, on 2 occasions in females and 1 in males, or the catheter-associated specimens. Generally, we say you need to monitor residual urine, but it's not mandatory to have cystoscopy or upper tract imaging. If proteus, you need to exclude stones, and men must have a rectal examination to rule out prostate involvement or abscess. Again, the recommendations generally do not screen or treat bacteria in following conditions. So patients without risk factors and well-regulated diabetes and so on. So if the risk factor is very low and they otherwise have got catheters or transplants, you do not have to screen or treat them routinely. However, you must treat them prior to any endoscopic urological procedure in pregnancy, and the treatment should usually be followed after a urine culture. What is the summary of evidence? Again, as I said, you don't always need to treat. And remember, it's in fact harmful to treat in patients who are asymptomatic with recurrent UTIs. You do not have to treat, or you might do more harm. It is, however, beneficial prior to urological procedures and in pregnancy. Recurrent uncomplicated UTI in females, what do we do? Urine dip test and or the culture, post-wed residual, consider an ultrasound. Cystoscopy, I have to say, is not routinely indicated, although a lot of places do it. And the treatment-wise, eradicate any previous UTIs, continuous or postcoital prophylaxis can help. And sometimes if it's a high post-wed residual, you might need to consider intermittent catheters. But I think these will be covered in the following talks. Now, diagnosing uncomplicated pyelonephritis, I just wanted to cover one point here. If the patient remains febrile after 72 hours of treatment, you must arrange additional imaging apart from simple ultrasounds, such as a CT scan, etc., to rule out abscesses. So after 72 hours, if they're still febrile, you need to think ahead and you need to think further and do something else. What about pregnancy? It is not uncommon. However, a lot of asymptomatic bacteriuria in pregnancy will then go on to develop pyelonephritis. You must do an ultrasound, and bacteriuria, you screen for them, treat them with antibiotics. So in pregnancy, it is very important to treat them with antibiotics. What about postmenopausal females? It is much more common in institutionalized women, especially with catheters, or if they've had a functional decline. Atrophic vaginitis is quite closely associated with it, and other things that increases your post-wed residual urine. And in these, asymptomatic bacteria in elderly should not be treated. However, you can try topical estrogens, etc., which can be helpful. What about in males? As a general rule, apart from what we have said, generally there is a prostate involvement as well, and you must try and rule that out. It can have a transient increase in the serum PSA, so it's not a good time to measure a PSA. You should always do urological investigation if they're in adolescents or men with febrile UTI and so on, because there might be complicating factors that need to be sorted out. And generally speaking, a longer course of antibiotics is required, especially something that has prostatic involvement. And this is especially true for elderly men. This is some work we had done about resistance in UTIs across 5-year period, and we generally found that nitrofurantoin, and again, this is something specific to your region and your hospital. It is not something that is always valid everywhere. So you must know your own local resistance patterns. And based on this graph, we recommended nitrofurantoin as the first line for female UTIs with normal renal function, gentamicin for prophylaxis for endourology, and so on. So this is something that you must try and do in your setups. But gradually, the antibiotic resistant trends change over time, and you must make sure that you monitor these trends and change the protocols accordingly. Some associations. This is something that I always felt was very true, and we found in our studies. So we looked at patients with recurrent UTIs who also had kidney stones, and we followed them up for 12 months. and it had more than 100 patients. And these are patients who had either a positive urine culture, almost 80%, or had a recurrent history of UTI in the last 6 to 12 months. And when we looked at the association of UTI and stones, we found that over 3 months, 6 months, and 12 months at all time points, clearing stones was significantly in favor of getting rid of UTI. So if you wanted the UTI to be better, you had to treat the stones and get rid of the stones. And that effect held for 3 months, 6 months, and 12 months. So if I have patients with UTI and we found an incidental stone, I always try and say that, look, if we treat them, it is likely, not always, but it is likely that the stones will get better. The infection will get better. And this is a recent study we have just looked at with a control patient, so 820 stone patients and almost 2,500 control patients, longitudinally followed up over 19 years. And again, it shows clearly that having kidney stones is much more likely to be associated with urinary tract infections. Thank you very much.